Good afternoon, everyone, and thank you for joining us. So my name is Steph Kershaw. I am a postdoctoral research fellow at the Matilda Centre for Research in Mental Health and Substance Use, which is located at the University of Sydney. And I'm also the project coordinator for the Cracks in the Ice online toolkit. So I'd like to start by welcoming you all today to the webinar. It's great to have you with us. Today is a webinar in a series which will be focused around crystal methamphetamine, or ICE, for the Australian community. And this is running as part of the Australian Government Department of Health funded project, Cracks in the Ice. So if you haven't already seen our website, cracksintheice.org.au, I would encourage you to visit it. We have a number of resources for family and friends, health professionals, and the general community. So in a moment, I'll introduce you to our speaker for today. But before I do, I'd just like to let you know that as participants, you are in listen-only mode, which means that we can't see or hear you. However, you will notice that you have a Q&A button and also a chat button at the bottom of your screen. And so you can type in any questions that you have during the webinar through the Q&A button, and we will have a short question and answer time at the end of the webinar. We will also be recording today's session, and the recording as well as the slides will be made available to you through the Cracks in the Ice website. So I'd like to introduce our presenter for the day, and this is Professor Catherine Mills. So Professor Mills is a NHMRC Senior Research Fellow, and she's the Director of Early Intervention and Treatment Research at the Matilda Centre. She has an award-winning program of work focusing on improving our understanding of the relationship between mental and substance use disorders, evaluating innovative treatment approaches, and improving the translation of research into practice. In particular, Professor Mills' work focuses on the challenging area of post-traumatic stress disorder and substance use. And Professor Mills is recognised as a leader in the field, published and presented widely in the area. So we are very lucky to have her with us today. So thank you so much for joining us, Professor Mills. I will hand over to you to make the presentation.
Great, thank you, Steph, for that very warm introduction. And thank you everyone who's attending today. I'm really delighted to be able to present this webinar. But I'd like to start by acknowledging the traditional custodians of the lands that we're meeting on today, which for me in Sydney is the Gadigal people of the Eora Nation. I pay my respects to elders, past, present and future, and would also like to acknowledge any Aboriginal or Torres Strait Islander peoples who are here with us today. And also like to acknowledge and pay my respects to people who are with us today who may have lived experience of substance use or mental health conditions. So as Steph said, I've been asked to present on the topic of trauma and substance use, and it is substance use more broadly, but everything that I'll be talking about also pertains to methamphetamine. And the large number of people who've registered for this webinar is really indicative of this being an issue that is very close to people's hearts, either in their professional roles or perhaps on a more personal note in relation to your own experiences or people who are close to you. I'll be talking quite broadly today about the nature of trauma exposure and post-traumatic stress disorder and its effects, the link between trauma and the use of alcohol and other drugs, and approaches to managing and treating trauma symptoms. But each of these could easily fill an hour themselves. But I just want to note that even these broad conversations can sometimes be distressing for people and sometimes affect us in unexpected ways. So please feel free to drop in and out if you need to, take a break. You can always download and catch up on the webinar at a later date if you wanted to. And Steph will also be putting up some contact details of resources and helplines that might be useful to people if you do find that it's distressing at all. So firstly, I'll start just by defining what it is I'm referring to when we're talking about psychological trauma. Because the term trauma is used commonly and very broadly by people when referring to a range of occurrences, from something that has happened that may be mildly distressing right the way through to horrific life-threatening events. So when I'm talking about psychological trauma today, I'm talking about events where a person has experienced actual or threatened death, serious injury, or sexual violence. And they may have experienced that either via direct exposure, that it's happened to them personally. They might have witnessed one of these events happening to someone else, or been indirectly confronted with such an event that has happened to someone close to them. And people may also experience them via repeated or extreme indirect exposure to aversive details events. That's typically thought of in relation to emergency services personnel in their professional duties, but it can equally apply to many other occupations, and particularly in the health field and people working with trauma specifically. And these traumatic events, they might be a one-off event, such as a life-threatening accident, natural disaster, or a one-off physical attack, right through to more prolonged events, for example, prolonged child abuse or domestic violence, or combat exposure, for example. So as you can imagine, it can incorporate a very large number of different types of events. But basically, if you just keep in mind that it's any event where a person perceives that their own life or safety or that of someone else to be at serious risk. Our most recent estimates of the prevalence of trauma exposure and post-traumatic stress disorder and other mental health conditions is the Australian National Survey of Mental Health and Wellbeing, which was conducted back in 2007. It was a nationally representative survey funded by the Australian Government Department of Health and conducted by the Australian Bureau of Statistics on close to 9,000 Australians across the country. So we're definitely overdue for another survey to be able to provide us with some more recent estimates, and hopefully that's on its way. But the findings of this study back in 2007 indicate that most of us, about 75%, will experience a traumatic event at some point in our lives. And of those, 75% will experience their first trauma before the age of 16, so during childhood. And about 2/3 of us will experience multiple traumatic events. And although men and women in Australia are equally as likely to experience trauma, there are some differences in the types of trauma they're exposed to. So men, for example, are more likely to experience events like combat exposure, being physically attacked or perpetrating a physical attack as well, being in life-threatening accidents, whereas women, on the other hand, are more likely to be badly beaten up in the context of a romantic relationship, witness domestic violence at home, have been raped or sexually assaulted. But regardless of the type of event and whether or not it's a one-off or prolonged, traumatic events are life-changing and typically redefine a person's views about themselves, the world around them, and how they relate to it. And for those who are unfortunate enough to have one of those events occur during childhood, those beliefs may become particularly well entrenched over time. The consequences of trauma exposure as well can be very broad and long-lasting, including difficulties in regulating emotions and developing interpersonal relationships, cognitions and memory. And research has shown that it does actually have an effect on not just the structure, but the functioning of the brain. Those things then consequently impact adversely on multiple life domains, including a person's education, their employment, their ability to form and maintain interpersonal relationships, the likelihood of engaging in high-risk behaviours or becoming aggressive, the likelihood that they may be imprisoned or homeless, and also increases the likelihood of developing chronic physical health conditions, substance use, mental health disorders, as well as attempting suicide. And all of these domains are associated with very high levels of service utilisation, whether that be in health settings, social services, or justice, and also leading to, unfortunately, premature death. And again, the impact is particularly pronounced when the trauma is prolonged or if it occurs in childhood. Childhood trauma has consistently been found to have a strong and enduring associations with all classes of mental disorders across the lifespan and around the world. But one of the most pivotal studies that's been conducted was the US Adverse Childhood Experiences Study, which sought to improve our understanding about the impact of not just childhood trauma, but other adversity as well, on physical health and mental health outcomes. It was conducted back in the 1990s and looked at the impact of experiences like psychological, physical or sexual abuse, violence against the mother in the home, living with household members who may also have problems related to substance use or their mental health, or people who have been imprisoned. And that study showed that experiencing adverse events in childhood was associated with increased rates of alcohol abuse and illicit drug use, an earlier age of onset of illicit drug use, and poorer mental health and increased likelihood of attempted suicide. And there was also a dose-response relationship observed, so the risk of the occurrence and severity of each of those outcomes increased with the number of adverse events that someone had experienced. A similar pattern has emerged from analysis of the Second National Survey of Mental Health and Wellbeing in 2007, which found that 1/3 of adults who had reported exposure to childhood trauma also developed a substance use disorder, predominantly alcohol or cannabis. And this rate was nearly 3 times that of adults who had never experienced trauma, and about 30% higher than that of people who only experienced trauma in adulthood. But the most common mental health condition to develop following exposure to a traumatic event that can be attributed very directly to the experience of trauma is post-traumatic stress disorder. And the types of experiences that a person will present with when they have PTSD include having intrusive memories, where the event keeps coming back to them, bad dreams related to what happened, flashbacks where they can actually feel as if the event is happening again, and physiological reactivity when they're reminded of the event, so increased heart rate, sweating, shaking. They also, quite understandably, try to avoid thinking or feeling about the event, and also people, places and activities that might serve as reminders of what happened. Have a lot of negative thoughts about themselves and the world, perhaps excessive self-blame as well, and decreased interest in activities they may have previously enjoyed, as well as decreased ability to feel positive emotions like love and affection. And lastly, there can also be symptoms of alterations in hyperarousal and reactivity. So a person may come across as being more irritable or aggressive, be hypervigilant, always on the lookout for danger, and sometimes experience exaggerated startle responses. And the most common, I think, example that you see often in movies is the combat veteran who hits the deck after hearing cars backfire, feeling that they're back in combat. And also difficulty concentrating or sleeping. And this difficulty sleeping is a bit different to the experience of the bad dreams and nightmares. It's more about the body continually being in that hyper-aroused state, ready to act should they need to, if a dangerous situation comes to pass. And as you can imagine, many of these symptoms cause significant distress and often impairment in a person's social, occupational and other areas of functioning. And that, as I mentioned, that can be long-lasting. But what it can also be conceptualized as is an adaptive response to fear that has become maladaptive. So responses that in the presence of a potential threat can keep you safe. So for example, that it keeps coming to mind so that you don't forget that you need to be wary of these events. You're always on the lookout for danger, so that if you needed to fight or flee, you could do so. But the problem arises when the alarm is active or being set off in situations where there isn't actually any threat. There can also be a considerable variation in people's responses. So some people may have more of one cluster of symptoms than another. And while many people will start to develop symptoms, or those who are going to, will have them immediately or very soon after the event, for others the onset may be delayed. And they may emerge later following a triggering event. And that doesn't always have to be another trauma or further negative events. For some people, it can be, for example, the birth of their children. They may have experienced childhood trauma, thought they were going along fine, and had coped or dealt with it. But then when their own children are born, those symptoms start to emerge. Before discussing PTSD in more detail, I just wanted to also note that people with PTSD also tend to have high rates of other co-occurring mental health conditions, such as depression or anxiety and borderline personality traits. And perhaps somewhere around a half may experience a more complex form of PTSD. So complex PTSD has only recently been recognised as a distinct disorder in the latest revision to the International Classification of Diseases, but it has a very long history. For more than 30 years, clinicians as well as clients have advocated for recognition of a more complex form of PTSD that appeared to develop after a person had experienced prolonged or repeated childhood trauma of an interpersonal nature. However, research examining the construct has been really limited because of divergent views on how it comes to be and what it looks like. So ICD-11 settled on the addition of 3 symptom clusters that a person must meet in addition to those symptoms of PTSD that reflect difficulties with regulating emotions, such as having high levels of emotional reactivity, outbursts, dissociative symptoms, or numbing. Persistent negative beliefs about oneself, including feeling worthless, deep senses of shame and guilt about how a person responded or has dealt with the trauma, and difficulties in developing and maintaining close relationships. However, in the classification systems, they're deliberately not linking it to a particular type of event. The reason being is that while the more complex forms of PTSD are more often seen in people who've experienced childhood trauma that's been repeated and interpersonal or prolonged in nature, it does occur with other trauma types as well. So I wanted to, I guess, flag this because due to the recency of the introduction of this diagnosis, there is very little research on complex PTSD. So the rest of what I'll be talking about today is in relation to PTSD, but it's worth keeping in mind that a considerable proportion of those included in the research I discuss are likely to also meet those additional complex PTSD criteria. And Logan Harvey, who's a clinical psychologist and PhD candidate at the Matilda Centre, is also undertaking his studies on this exact area. So hopefully in future webinars, we might be able to present more on the situation regarding the conceptualisation of complex PTSD in relation to Australians with substance use disorders. So back to PTSD. Who develops PTSD? I think it's important to remember that while a large number of people will experience symptoms in the immediate aftermath of a trauma, most symptoms will subside within between 1 and 3 months. And it reflects a natural processing of what the person has been through after something so confronting. In Australia, only 1 in 10 people will actually meet diagnostic criteria for PTSD in their lifetime. And while it can occur at any stage of life, about 1/2 of cases will emerge by the time people turn 26 years of age, so the mid-20s. And while 92% of Australians will achieve full remission, as in will have no symptoms at some point in their life, it takes an average of 14 years before that's the case. And for more than 1/3 of people, they'll continue to have symptoms for more than 30 years. But the decline in symptoms also isn't necessarily linear. It's very common for people to experience periods where their symptoms may be more prominent, for example, during periods of stress or subsequent new traumas. So it wouldn't be surprising at the moment, for example, if during the COVID-19 crisis, if other issues are also coming to the surface for people. But there may be other times that a person has no symptoms or very minimal symptoms and they're able to manage them quite well. Coming back though to who develops PTSD, there are a number of pre-trauma factors that can influence a person's susceptibility, including the number of traumas they've experienced. So if they've have a history of trauma exposure and experience another trauma exposure, they're more likely to develop PTSD. Personal or family history of psychiatric disorders. Female sex, women are consistently found to be twice as likely to develop PTSD than men. And low social support. And with the exception of sex, all of these factors are also common among people with substance use disorders. Then there are also factors associated with the event itself and how the person responded in that moment. So the likelihood of developing PTSD is increased the higher a person's level of distress and the higher the perception of threat at that time. Also more likely if a person experiences peritraumatic dissociation, which is when a person essentially loses their ability to perceive themselves in time and space. So at a very extreme end of the spectrum can be where people do have out-of-body experiences. But also related to the trauma type. So if it's one that is violent and interpersonal in nature as well, they're more likely to lead to a diagnosis of PTSD. But what is also critical is what happens immediately after the trauma. And one of the most significant factors is the amount of social support that someone has during that time. Being very protective if you have it, and being a high risk factor if you don't. Other risk factors are symptom severity during those first 1 to 2 weeks, and whether or not a person continues to experience dissociative symptoms. Also, if a person has negative interpretations or starts to ruminate about the trauma and what happened, if they have ongoing physical complications or injuries, and also avoidance, which brings me to substance use. So I briefly mentioned earlier that substance use commonly co-occurs with trauma exposure, but its development is typically mediated through the development of other conditions such as PTSD. So by that I mean it's not necessarily all about the trauma itself, but it's about whether or not the person developed problems subsequent to that that can increase the risk of problematic alcohol or other drug use. And findings from the National Survey of Mental Health and Wellbeing found that 65% of men and 1/3 of women with PTSD also had a co-occurring substance use disorder. And more recent analysis of that survey has also shown that the odds of a person transitioning from substance use to use disorder is increased in the presence of PTSD. Among those who do develop both PTSD and substance use disorders, for about 2/3 of men and half of women, the post-traumatic stress disorder actually precedes the development of the substance use disorder. Earlier research from data collected as part of the first national survey, which was way back in 1997, and at that time trauma exposure was measured differently, as was PTSD and substance use. But it does give us more of an idea about the differences in prevalence of these co-occurring conditions depending on the type of drug. So what we found was that the most common substance use disorder among people with post-traumatic stress disorder is alcohol. But if you look at it the other way, only 5% of people with an alcohol use disorder have PTSD. When you look specifically at people with substance use disorders, PTSD, excuse me, PTSD is most commonly found among those with opioid, sedative, and amphetamine use disorders. So 1 in 4 people with amphetamine use disorders were also meeting criteria for PTSD. When we look at rates of PTSD among people seeking treatment for substance use disorders, we find that trauma exposure is almost universal. And the most common types that they experience are witnessing serious injury or death, being threatened with a weapon, held captive or kidnapped, or being physically or sexually assaulted. The vast majority have experienced multiple traumas, and there are very high rates of childhood trauma. Up to 2/3 of alcohol and other drug clients have also been found to experience symptoms, not symptoms actually, actually screen positive for a diagnosis of PTSD. That is incredibly high compared to the population prevalence, as I said, that is more around that 1 in 10 mark. For many people, self-medication plays at least some part in this relationship and in the development and maintenance of substance use disorder. So the self-medication hypothesis postulates that substance use disorders develop as a consequence of repeated substance use in an effort to try and ameliorate some of those trauma-related symptoms that a person experiences, and then through that continual use and the need to use increased amounts, develop a separate substance use disorder. But it's more complicated than that. I think there are a number of other theories around why these conditions commonly co-occur, including the high-risk hypothesis, which is that people who have problems related to alcohol and other drugs, particularly perhaps illicit drugs, and the lifestyle associated with that, places them at higher risk for experiencing trauma and also from intoxication. That then increases the likelihood of developing PTSD. It is also thought that people with substance use disorders may be more susceptible to developing PTSD following exposure to trauma, either because they lack the coping skills necessary to be able to deal with it, a traumatic event if it happens, but also maybe more susceptible because of having a dysregulated stress response system that's been brought about from repeated cycles of intoxication and withdrawal. So they're more primed to develop PTSD following trauma exposure. And as with all co-occurring conditions, there may also be common factors that underlie both the increased likelihood of PTSD and the increased likelihood of substance use disorders. And they might be other psychological factors, environmental, biological. So I mentioned these by way of explaining the link, but regardless of how it happens, once a person has both traumatic stress disorder and a substance use disorder, they can keep maintaining and exacerbating each other. Studies have also examined how changes in the symptoms of one condition changes the symptoms of another. And these have shown that trauma, PTSD, and substance use are all integrally related. Specifically, improvements in PTSD symptoms have been found to lead to improvements in substance use, but the reciprocal relationship isn't observed. So even if a person has been able to achieve substantial reductions in substance use, PTSD symptoms often don't remit. Rather, they actually tend to get worse in the absence of the substance use, particularly if it has served as that self-medication function. But that makes it very difficult for people to be able to maintain abstinence or reduced use goals that they may have. So it really highlights how important it is that we address trauma-related disorders to try and improve treatment outcomes as well for people who have substance use disorders. In addition to the distress that is associated with having a substance use disorder and PTSD, though, some other reasons why we're also concerned about how common this is because people with both conditions tend to present with a poorer clinical profile more broadly, in that they have poorer physical health, mental health, and psychosocial functioning. So that then has a flow-on effect and often leads to poorer treatment outcomes across those domains. Which brings me to the approaches that are used to manage and treat trauma and substance use. There has been increasing advocacy for trauma-informed care and practice in the context of alcohol and other drug and mental health services. Trauma-informed care is a service-level approach which assumes that all clients have a trauma history and is sensitive and responsive to those needs. So while I'm talking about these trauma-informed approaches to care as being derived with reference to healthcare or social service providers, the principles are also relevant for everyday interactions with family and friends and others in the community as well. Trauma-informed practice, on the other hand, is the provision of psychological treatment for trauma-related conditions, which is only provided through, or should only be provided by, trained and accredited professionals. But it can also be very useful for people outside the healthcare system to know about these and the evidence base for them in terms of knowing what treatment options might be available to you or to someone close to you. So the basic tenets of trauma-informed care are, as I said, the recognition of the high rates of trauma exposure in the patient populations that they serve, and providing a safe environment and services that accommodate the needs of clients presenting with a history of trauma exposure. So it's about both the physical safety of the environment as well as psychological safety. And it's about understanding the potential impact of trauma on treatment and creating an environment that is more healing and less re-traumatizing. And there are many ways that this can be sort of enacted in services. And some of them, for example, even as simple as what movies people might be able to watch when they're in inpatient services in communal or common areas. Movie displaying violence or sexual violence may not be the most appropriate one in that setting. At a minimum though, what's recommended is that everyone in the alcohol and other drug workforce and more broadly in healthcare has an awareness of the extent of trauma exposure among their clientele, that they understand the consequences of trauma exposure and its potential to impact on a person's recovery, that they're able to recognise the signs and symptoms of PTSD and other trauma-related disorders, and then also integrate that knowledge into their practice. So as I mentioned, I could give a whole webinar itself on trauma-informed care alone for clinical audiences. But here, I just want to point to those who are interested to a few useful resources that can provide more detailed guidance on how to implement a trauma-informed care approach within services. All of those, bar the bottom one, are Australian resources. And in terms of international resources, I'd direct you to those at the bottom by SAMHSA in America, who has been doing this for a long time. But in terms of what people can do, I think one of the most important things that everyone can do is normalizing and validating a client's experience. Psychoeducation often gets underrated, but having brief psychoeducation about common reactions to trauma and symptom management has been found to be of some benefit to clients. In particular, normalizing symptoms can help to alleviate some of the shame and the guilt that people may be feeling about either what happened or not recovering sooner. So we developed a booklet as part of a broader series funded by the Australian Government Department of Health to try and help provide that for people, but also for clinicians to be able to perhaps start facilitating a discussion about the relationship between these conditions, how people can manage their symptoms, and what treatment options may be available should they wish. And we're hoping to revise these at some point. I guess we view it particularly as a very good starting point and a stepping stone for a person to understand where they are at now, and potentially provide a framework for developing more adaptive responses and coping skills. Because it's not at all surprising that a person may choose to turn to alcohol and other drug use or increased use to get some relief from their trauma symptoms because it works. The only problem being that it's not a great long-term strategy. On the contrary, as an avoidance strategy, it can actually prolong and interfere with a person's recovery. In terms of psychological approaches to treating traumatic stress in substance-using clients, there has been a reluctance in the past among clinicians to address PTSD among substance use clients. And that has mainly been out of concern that people have been worried that people may be in a vulnerable spot when they're trying to stop using or reduce their use, that there is a need for substance use to be treated first so that people can engage in therapy and benefit from it optimally. And for some people that, people have, in the past, people have been told they often need to be abstinent for quite a prolonged period before they can even start to address their trauma and PTSD. So they're receiving that sequential model of care on the left-hand side of the screen there. Unfortunately, what tends to happen is, as we mentioned before, people might, really try to do that, but unfortunately, their symptoms might become exacerbated in the absence of any other coping skills. They're more or less doomed to failure without those supports in place, so they don't ever end up getting the treatment for PTSD they need. In some cases, people receive a parallel model where they might be treated for their substance use in one setting and trauma in another, but sometimes there are issues with that and people falling between the cracks of services. But what experts have been advocating for quite a long time is an integrated model of care where both substance use and trauma and PTSD are treated at the same time by the same clinician. And it's not only more efficient, but this is the model that clients also say that they would prefer to receive. There have been a growing number of studies examining integrated treatments over the last decade or so. And existing approaches can be divided into two different types. One, present-focused therapies. One which people may be more familiar with because it's the most researched one is called seeking safety. And these types of therapies, though, don't involve a person going back and addressing the trauma that happened to them. It is solely focused on management of symptoms that a person is having now and provision of coping skills as opposed to actually confronting what's happened. Past-focused therapies, on the other hand, are ones that do involve the person revisiting what has happened to them and talking about that in detail and how that has affected them. And a recent Cochrane, relatively recent, 2015, Cochrane review concluded that at the moment, although present-focused therapies were the mainstay for a long time in the absence of anything else, there's actually little evidence to support those therapies. And individual past-focused therapies delivered either alongside alcohol and other drug treatment or in an integrated fashion can help to reduce both PTSD severity and alcohol and other drug use. Those, I won't go into these in detail, but as I mentioned, past-focused therapies, they typically involve exposure techniques where a person is exposed to both the memories of the event through their retelling of the story, which is imaginal exposure, but also physical reminders of the event through real-life exposure to perhaps people, places or situations that they've avoided. Importantly though, this is about safe situations. It's not about putting the person in danger at all, or about confronting perpetrators, nothing like that. It's about addressing avoidance that is impacting on a person's ability to live the life that they are wanting to live. So traditionally, exposure therapy, people have been concerned about exposure therapies being conducted in people who have substance use disorders. Again, based on that concern about whether or not the emotions would be too overwhelming and possibly lead to more substance use, but the evidence actually suggests that's not the case. It doesn't lead to exacerbation of substance use or severity of substance use disorder, and on the contrary, can actually be protective against relapse. Two of the studies examining the efficacy of exposure-based therapies, integrated therapies for substance use and post-traumatic stress disorder have been conducted in Australia, one of which focused on alcohol, excuse me, and the other which we conducted focused more broadly on any substance use disorder and any trauma types a person might have experienced. And that was looking at a treatment called concurrent treatment with prolonged exposure, or COPE. And this was a world first randomized controlled trial conducted with colleagues at the Medical University of South Carolina, who had developed an earlier form of this treatment in the 1990s. And what we found was PTSD symptom severity did decrease significantly, and far greater in the group who received COPE as opposed to treatment as usual. And this was accompanied by concurrent reductions in severity of substance use disorder. He also not just reduced severity of symptoms, but also found diagnostic shifts in relation to PTSD. So while everyone in the sample met criteria for PTSD at baseline, and actually they had very severe levels of PTSD, at follow-up, close to half of those who received COPE had lost their diagnosis, compared to about 80% of those in the treatment as usual arm. Importantly, the vast majority of people, I think, who were in that COPE arm of the trial continued to use substances in some way throughout treatment. So while ongoing substance use might impede therapy, or perhaps it might mean that progress is a little slower than if people were completely abstinent, people do achieve reductions. And people can benefit from that treatment without waiting to the point where they become abstinent. And also importantly, the changes in PTSD symptom severity weren't influenced by whether or not a person had other co-occurring conditions as well that they were dealing with, or the number of traumas that they'd experienced, or types or number of substances they used. So the treatment is sort of more broadly applicable to the range of clients you might see in a treatment setting. And the participant feedback was actually really positive. There was some negative, but the negative was all in relation to logistics, in terms of coming to see us in places such as Randwick at the time, which didn't have great public transport to get there. But people were saying a lot of positive things. The best thing they've done for themselves helped them to see that link between their substance use and their trauma, that it didn't freak them out anymore. Excuse me. And also many people saying that they'd never actually been talked to about it before, and this is something that we commonly come across, and that even having a name to put to their symptoms, or a description that these are normal things that they're experiencing, that they're quite common, helped people. And although the retelling of the trauma experience was often found to be the hardest part of treatment, people also said that it was the most helpful. So the treatment manual for that program has subsequently been published by Oxford University Press, and there's also an accompanying workbook for clients as well. And that COPE program has also been the most researched past focus therapy to date. So several more studies have been conducted since then in Sweden and the US among community samples in veterans. And at the moment, we're currently conducting another randomized controlled trial looking at a modified version of the PROPE program for adolescents and young adults aged between 12 and 25 in the hope that we might be able to get in a bit earlier. You know, hopefully before people start to get into that cycle of PTSD and substance use disorders. So we are currently recruiting in Sydney, but unfortunately our recruitment and delivery of therapy is paused at the moment because of COVID-19. But if people are interested, please feel free to register the website or get in touch and we can provide more details about that. Excitingly though, there are a number of other past focus or trauma focused therapies that are also being examined at the moment, including other modified prolonged exposure techniques, ones involving EMDR and cognitive processing theory, which is great because we really, you know, not trying to say in any way, shape or form that there is only one type of treatment that people should have. We need multiple different types of treatments that are going to suit people differently. And I think that's also where some of these present-centered therapies do come in, is that some people will not want to ever do exposure-based programs, and we need to have other options. So just to summarize, trauma, exposure and PTSD and substance use are common and can be associated with significant harms and poor treatment outcomes, but there is hope. We've found growing evidence of the safety and efficacy of trauma-focused treatments, with people not getting worse and on the contrary, getting better. But I'll just also leave you before we open up for questions and discussion with, I guess, some of the challenges that we face moving forward, and is how we build resilience in young people and adaptive coping strategies when adverse events occur. And I know this has been a big topic of conversation, particularly around the bushfires this year. But also, how do we support people to seek help when they need it and intervene early, rather than once things have become well entrenched? And how do we incorporate the evidence-based treatments into practice? You know, we've made some headway in terms of trauma-informed care, but how do we upskill healthcare professionals and the field to be able to deliver that trauma-focused or trauma-informed practice care? Thank you very much.
Thank you so much, Professor Mills. That was a really interesting presentation, and particularly about how we all need to recognise the importance of trauma, particularly in relation to AOD and in therapy. We do have a number of questions. As you mentioned, this session has been overwhelmingly popular. We reached, for the very first time in the record of Cracks in the Ice, the number of live participants that we could have. So apologies to anyone who has to watch the recording instead of being able to join us live. So I'm going to kick off with a few questions.
Mm-hmm.
So, has there been a study done of PTSD and substance use in the prison setting? And do they have a higher use of substances in that area?
Yeah. There has been, but it's still very much in its infancy. We did one study, and the only study that I'm aware of to date, among male prisoners, and that was using a modified version of the Seeking Safety program. The reason being is in our consultations with clinicians and others working in justice, health and corrective services, was that at a time when someone is imprisoned, the trauma-focused therapies are probably not the best idea. And some of the symptoms that people are experiencing are actually ones that are keeping them safe whilst in prison. So it's a really difficult to juggle. The helping people improve symptoms whilst also acknowledging that they are in situations of ongoing threat. But it was a small pilot study. I think we only had 30 men involved in that, but there was huge level of gratitude, I think, as well, just that that people were asking them about their trauma experiences, I think, from the participants. And we did find that they did benefit, but the benefit was no greater than that obtained through treatment as usual, basically.
Oh, okay, right.
Yeah, but it's something that we would definitely be keen, and I know that others internationally are also keen to further explore in that population, because yes, trauma exposure, substance use and PTSD, I mean substance use disorder and PTSD are two of the most prevalent conditions among both male and female prisoners.
Oh, it sounds like a great opportunity waiting to happen.
Yes, we've tried a few times with no luck, but I'd be very interested if other people are wanting to do that too.
Great. Someone was wondering if you could give examples of exposure therapy for a client.
Mm-hmm. So yes, I'll start with the in vivo exposure, just to give an example of what that real life exposure might look like. So for example, one of the people in our study had experienced a physical attack when in the context of going shopping. From that point, she developed an extreme fear of going anywhere near a shopping centre, and this was hugely problematic because she needed to go to the shops to get food and get her other necessities, and you know, it was previously something she also liked to do. So in that example, the graded exposure to start with just driving to the shopping centre with a friend and parking there and staying in that setting. The important part for the in vivo exposure to be successful and have an impact is that people do stay in the scenario. It's not sort of good enough for someone to go and then go, okay, I've been now, I'm really anxious, so I'm leaving. That just further reinforces the anxiety. So people have to kind of force themselves to stay until their anxiety has reduced by at least 50%. Gradually then, you step it up. So then a person might drive to the supermarket themselves, get out of the car, go to the doors and stay there. Then gradually into the centre, sit at a bench with their friend and sit there for a while. Till eventually the friend is no longer there and the person is going by themselves. So that's one example, but there are lots of kind of different examples where people avoid perhaps crowded places, public transports, even entire suburbs. That has a real impact, for example, on things like employment that they try to get reintroduced to.
And I guess, is there any conflicting research around exposure therapy, whether it's best for some people and not for others? Someone wrote in that it was their understanding that in the US military, perhaps that they no longer do exposure therapy. In your knowledge, is that true?
Not to my knowledge, but I'm not necessarily most up to date on what the US military are doing. It was also one of their gold standard measures of care that they were using, various different types of exposure-based therapies. In particular, though, with veterans as well, virtual reality type exposure techniques. I think we don't know enough to sort of say. So far, many of the conceptions of who will and won't benefit from exposure therapy have, as I mentioned, come from concern, but not necessarily been borne out by research. But I think clinicians also definitely, you know, need to use their own judgment about, is this appropriate now? For example, someone might have other needs or be in a setting where it's not appropriate. For example, we wouldn't want to be doing exposure therapy with someone who's currently in a domestic violence situation or continuing to be exposed to traumatic events. So that might be where the combat exposure, you know, it might be okay for veterans, but maybe it's not the active personnel that they would do it with. And the main reason, I mean, the issue there is safety. That's the predominant concern.
Yeah, no, that makes sense for sure. And I guess one of the other ones around exposure therapy is how do you manage exposure therapy alongside a substance use disorder? So the example that this person is given for the impact of exposure on clients when they are under the influence of substances or experiencing heightened emotions associated with withdrawal. Would that exposure therapy be appropriate in that circumstance?
So we definitely encourage people to not be under the influence of substances when they were coming to their sessions, because that would absolutely interfere with their ability to be able to engage and learn from those sessions. And apart from perhaps, you know, whatever they're medicated to take for their functioning. And we would also encourage people not to use as much as possible in between sessions, but of course some people did find that they needed to. Very few people, but some, reported that they felt there was an increase in their substance use related to some of the exercises. But this can also be an opportunity as well to see and address those issues, because lapses are, of course, in substance use very real, very normal phenomenon for people to go through. Sorry, the second part of your question.
No, that's okay. I think you answered everything. We've got time for maybe another couple of quick questions. So perhaps we'll give you a rest from exposure therapy and let your brain think about something else for a moment. Someone was wondering whether constant intensive bullying at school would be classified as a traumatic event or PTSD.
I would say so. I think it's sort of, it depends again on that, you know, technically, I guess, according to the diagnostic criteria, if the person is perceiving threat to themselves, and that could be verbal, it doesn't have to be physical. But if a person is scared and worried about their safety from that bullying, then yeah, it would most certainly count as something being traumatic. I mean, in the real world environment, I'm not sure necessarily how relevant, you know, talking about something is or is not traumatic. You know, it's kind of whatever the person is feeling and experiencing in relation to something that's happened to them. I think in the research field, though, it's important that we have particular definitions, mainly because it does impact very much on the type of treatments that may be recommended for people based on the symptoms that they experience.
Okay. Yeah, no, I think that answers the question. Someone was wondering if COPE, the program that you spoke about, could be delivered as a group-based program.
No. Yeah, no. It's very much written as an individual one-on-one, and I don't think it could be adapted to a group-based program. I'm not sure that we would want to either. There isn't a great deal of evidence on this, but that which does exist indicates that group-based psychotherapy, regardless of whether it's exposure-based or not, isn't necessarily going to reduce PTSD symptoms. And that can be a problem, particularly in substance use services where most of the therapies are delivered by peers or in group formats.
Okay, right. And would complex PTSD be considered as a type of PTSD, or is it a separate condition altogether?
Probably more that it's a type of PTSD. So the person still experiences all the regular PTSD symptoms. It's just that they typically have these additional groups of symptoms that they're experiencing that makes it more complex around their image of their self, their ability to form relationships and regulate emotions.
Okay, so kind of a type of PTSD.
Mm-hmm.
So probably time for one more question, and there's so many to choose from, so I apologise in advance to anyone who didn't get their question answered. If you are desperate to know the answer, you can always email me and I can get touch base with Professor Mills and see if she can provide an answer.
Yeah, very, very happy for people to email as well or get in touch if there are more questions.
Thanks, Kath. So I guess the question that stood out to me is, does family therapy, have a role in treating both PTSD and substance use disorder if the client is obviously consenting and family members are keen? Is there a role for the family and perhaps even friends to be involved in the treatment process?
Again, there's not a great deal of research evidence related to involvement of family. But I think that what does exist would certainly suggest that it could be helpful. The trial, for example, of the COPE treatment that was conducted among veterans recently, that does have a family component to it. And I know others who are in ours as well for adolescents and young people. We're also brought in a component that is for a caregiver, if the person would like somebody involved in that way to try and support them through therapy. I think, like you said, as long as there's consent from the person, having that extra support there for them can be quite helpful.
Yeah, of course. I guess a lot of the time it does come down to your support networks as well. With anything that you're trying to cover from. Well, that was a really interesting presentation. Thank you for being so patient with the many questions. There's even more waiting in the wings to hear about. But thank you everyone for being involved today and for coming along. I hope you all learnt something really valuable. You are more than welcome to get in touch with us, as I said, via email, and we'll try to respond to any questions or queries as soon as possible. So we will be holding more webinars throughout the year, and if you are interested, please subscribe to Cracks in the Ice and our mailing list, and you will receive future updates. So thank you everyone for joining us today, and I hope you will have a pleasant day.
Thank you.